Hey, section 5. I hope you are all doing well. This is our block 3, week 6 wrap up. Just to let you guys know, I'm in Minneapolis, obviously, and I am currently under about 12 inches of snow, believe it or not. This has been the worst spring imaginable. A year ago at this time, it was 60 degrees. Today, it's 28 and snowing. It's unbelievable. So if I sound a little annoyed, it's only because the weather is absolutely terrible here. Um, but I digress. Let's move on. So this is a good block. I felt like I got a lot of good conversation in this block. People were more active on the boards, and we got into some really good discussion. So I appreciate everybody doing that. Um, yeah, after the midterm and getting some information back, hopefully you were all able to take that information in and then come back and use it. I saw people using articles that to support some of their information. I saw people responding reasonable in a reasonable amount of time, entering into some good conversation. So keep up that good work. So key points for this block 3: symptom differentiation, peripheral versus spinal nerve. Remembering how we go from radiculopathy versus a peripheral nerve entrapment, understanding or at least in my groups, we talked about the Wayner criteria, understanding it's a really good criteria. It's not been validated. I don't know if it ever will. I got to think someday it will be, but I think we can't use it as gospel. We have to know that it has its limitations. We also have to remember that the median nerve is like the median nerve upper limb tension test A is like the straight leg raise for the lower extremity, right? And so we use that to rule in and rule out. So if somebody comes in with diffuse pain, neck pain, and arm pain, but they have a negative upper limb tension test, I'm certainly not thinking cervical radiculopathy, and I'm thinking more joint related, more weakness related, and maybe depending on where their pain is, but I'm not thinking obviously poor neurodynamics. We talked in a lot of the PowerPoints and the lectures in regards to nerve entrapment sites, right? Whether that be at the shoulder, the elbow, or the wrist. We talked about nerve fields, peripherally versus spinally, versus centrally. So understanding these and being able to differentiate. I had some conversations with the people in my group about are there times when you should not, when it's upper limb tension testing is unnecessary. The biggest pushback I get would be from irritability. I would argue that certainly irritability could be a potential reason not to do it, and it would then allude to the fact that you can do it on the contralateral side. If a nerve is really irritated, you do it on the contralateral side, you should be able to drive some pain into that ipsilateral side. So oftentimes, my kind of progression with somebody who's highly irritable is I will have them simply do the upper limb tension test 2B, which is just out with the arm into a little bit of abduction, a little bit of wrist extension, and let them just actively do that, right? And if they can't, then we'll go to the contralateral side. But outside of high irritability, I do an upper limb tension test on anybody with any kind of upper extremity pain, and I also do it on almost all people with lower extremity pain, whether it be heel pain or lateral knee pain, teasing out sural, tibial. These are all opportunities for us to make sure that there is not a neurogenic component. After all, what sends nociceptive signals to the brain? It is nerve tissue. So that nerve tissue. Now, if it's a tendinopathy, it can be a tendinopathy. Could there be a nerve? Could there be a nerve overlay on top of that? Yes. So I would argue that you should make sure that you do upper limb tension testing for anybody with an upper extremity problem, just to make sure you clear that out. Then in regards to, I wanted to point out this article in JOSPT published in 2017, so very recent, the systematic review on neuromobilization or the effects of. So CTS, there's no significant effects for outcomes, but poor quality design, no representation of practice, didn't include the recent Fernandez de las Peñas article, and didn't address sliders versus tensioners. I had questions about sliders versus tensioners, and I don't think there's really good clinical guidance as when to use either one. I think we surmise that tensioners are for people that you can be more aggressive with, and that and that sliders are for people that you just want to get moving. And there's no question that the research shows that sliders do move more than tensioners. I don't know. I don't know when we should use one versus the other. I too follow that paradigm, if you will. If I can get them into upper limb tension position, and they can get all the way into that position, then I'll put them in a tensioner position, and I'll put their arm fully extended, like in a median nerve. Put their arm fully extended. I'll put their palm up against the wall so their wrist is extended, and then I'll tip the side bend away, and I will be more aggressive. But I will fully admit there is really no research that guides us in that, and so there really is no right answer. Who knows? Sometimes when you just do the opposite, what if we gave somebody a tensioner who was highly irritable? Would all of those people get worse? I don't know. I think more research needs to be done. Lateral elbow, cervical guides only. No studies assess radial nerve, which could be closely associated with the condition of lateral tendinopathy. This is why I would highly recommend you test upper limb tension tests for people with any kind of upper extremity pain. You might be surprised. This is, in essence, what regional interdependence is all about. We already know that if you manipulate cervical spine, you can get a reduction in pain, in grip, an increase in grip strength, and a reduction in pain in people with lateral epicondylalgia. So it would make sense that there is a neurogenic component to this. Clinical reasoning pearl I'd like to share. This was a thought that was shared by a student, not in this section, but in another section. I learned the value of assessing neurodynamics can have in a successful plan of care. I was also reminded of the benefits of a more simplistic approach of focusing on 1 to 2 manual techniques with subsequent home exercises to determine the effectiveness. As a new clinician, I often get a little too excited and want to perform so many manual interventions during a single session. Same goes for home exercises. I often am reminding myself that giving a fewer exercises that the patient will actually do is better than too many that may overwhelm them. I think this was great clinical insight on this person's part, under recognizing that oftentimes less is more. And while you may have a whole litany of things to do, which is great because it means that you are prepared to address people in a variety of different ways, right? And that's really what having multiple things at your disposal it beneficial. Like you can know 6 different ways to manipulate CT junction, but you may do one way 75% of the time. But depending on body type, irritability, other things that can get in the way, you may need to call upon those other 5 different ways. And the same is true with upper limb tension testing and exercise. You may have a bunch of ways to do one thing, but in reality, it's just that doing that one thing and letting that patient focus on that, getting them to move with less pain, dampening down that nociceptive signal, that what allows them to move better. And so I think less is more is a good kind of mantra moving forward, especially for all of those who are trying to figure out in your clinical decision-making process based on what you know and what you have, how you move forward. So, next week, case project preps, post by Sunday, April 22nd. So, block 4 is for the case project. Block 4 has no quiz, so make sure that you get your quizzes done for block 3, but block 4 has no quiz. Weekend intensives, people have been wrapping those up. The goal here is to practice. Utilize the techniques in any manner that you can. Sometimes for patients who may not even necessarily need it, but you're just looking to practice. Start working on your action plans. Like, how am I going to be able to implement all of this information? How do you not let it just go by the wayside? Feel free to contact me with any questions. I'm looking forward to a strong Block 4. I thought Block 3 was really good. I really liked the engagement. I'll be shifting to Alpha and Charlie, and Laura will be dipping down into Bravo and Delta. Also, we'll be finishing up a Block 3 fit eval, so feel free to peek in to see what the fits are doing. Both Laura and Eric do a tremendous job. Hopefully you've enjoyed their insights. I couldn't do this course without them. I really appreciate their efforts. I think they have great clinical insights, and I think they're great clinicians, and they're getting even better as part of this fellowship. So check them out. Otherwise, enjoy your weekend. I'm going to try to dig out of this snow and hopefully be back at it on Monday. Take good care. Bye-bye.